Okay, first of all, so I'd like to thank you for joining us. The complex PCI 2020 virtual. This session is virtual theater number 5, taped live cases for calcific lesion. So I'd like to introduce Takashi uh, Akasaka. He's my co-moderator, and excellent panel discussion, Dr. An Thierry, Dr. Shigeru Nakamura, and Huay and Dr. Wu actually joined together. So Dr. Akasaka, would you introduce the first tip cases first?
Okay. We will have three case, and I would like to introduce a first case presentation. It's a tape live number 7 with interactive discussion, right? Non-atherectomy balloon. This will be presented by Dr. Duk-Woo Park, please.
Okay, thank you, Dr. Akasaka, and thank you, and the moderator and the panel. I'm very happy to introduce one of a very complex case and recently experienced this case. And during the lecture time, I have one discussion time, interim time, and then finish the lecture, I have remaining discussion time. This is one of the typical case of the severe calcified lesion, non-atherectomy balloon-based the PCI. This is my disclosure. And if I'm going to introduce this patient background, the 72-year-old male, and presented with effort-related chest angina, and 1 month ago, and the risk factor is a 55 PEG year history of heavy smoker, and also has hypertension, no diabetics. And the ECG shows there is no Q wave and the normal sinus rhythm. Chest X-ray was absolutely normal. And looking at the echocardiography and the ejection fraction, 59%, and just basal imperial wall, and there is some akinesia. Overall ejection fraction was absolutely normal. So, and we checked the coronary angiogram, looking at the RAO coral view, we can see the very, the severe and the calcified region and the very acute angle of sock osteum, and looking at the spiral view and the, definitely, and the 011 and distal lemon lesion, very severe calcified region. And this view shows how much, severe calcified region of the sock thoroughly nearly circulated calcified region. And there is looking at collateral from LCX system to distal RCA. So, and this is the RAO cranial view. You can see the very severe calcified region from middle RAD to the distal main. This is a cranial view. You can see the very severe calcification. Also, diagonal branch is not small. Definitely, we require protection wire. So, and this is RCA and take a long time to engage. And we use AL2 and anomalous origin, and the size is not so big, but the mid part, there is some toral obstruction. So, and the discussion, interim discussion point 1, and how do we treat? And the 72 male stable angina, hypertension, ex-smoker, lemon 3 vascular disease, and we have some interim discussion and the cavity versus PCI, PCI, which strategy in the left main PCI technique or heavy calcified region, how do you treat the non-atherectomy balloon versus if you're going to select atherectomy and the rota IVL laser orbital atherectomy, how going to treat the RCA or OMTA or PCI. So any comment for introduction, the interim discussion for this case?
Okay. Any question, any suggestion for these cases? Actually, this is typical, tough remain and sleep vessel disease. So personally, I think it is the really good candidate for bypass surgery, right? Very tough, very calcified region in the from the proximal part, right coronary arteries, and also region and the mid portion of the complete artery. Oh, all right. Uh, anyway, any other suggestion to that, Dr.
I agree with you, SJ,
Takashi?
about this case. If we measure the syntax score, it will be probably higher than 32. So I think if we go to PCI, we need to have good arguments according to the clinical status of the patient. So maybe the pulmonary function is not good because he's EV smoker, or maybe there is other comorbidities who may push to do PCI. If we have to do PCI, I think the right is an important vessel in this case. Not easy to treat, but you find a good catheter to have a good approach for treating this lesion, which is very severe. Then for the left main LAD, I think we can treat with 2 stents because the circ is also diseased. And of course, one thing which could be very important is vessel preparation in this case, because it's highly calcified. So I think that lithotripsy can be a good option for the left main and the LAD. Maybe not for the circ because access is more complex. So a good non-compliant balloon can be maybe a good option.
Okay.
I totally
Any
agree
others?
with
Antonio,
I totally agree with Thierry. This patient is not a diabetic patient. Am I correct?
Yeah, right. He's a
Yes.
non-diabetic patient. Yeah, just
No
hypertension.
diabetes. No diabetes.
Yeah, definitely.
So if this patient was a diabetic, I believe cabbage would be, no question, the first option. No diabetes, the targets are good size, 3.5 LAD. So I think the only difficulty is the circumflex is very ungulated, but I believe with current equipment you can do. So I think PCI is reasonable, but definitely you need a special lesion preparation.
Perhaps
Okay,
some form of
yeah.
CME might be helpful as well, to see what sort of calcifications we are dealing with in the LAD and circumflex. But I agree with that the RCA should be treated first.
Agree.
Dr.
Okay.
Wu, any other suggestion?
Because I think the difficulty, my point is probably the anomalous RCA. So if we consider that RCA, we cannot be treated, because I would like to treat the RCA first. If we can successfully treat the RCA, will because this lesion will be most like the equivalent left main plus RCA critical stenosis. And anomalous, if you can treat RCA first successfully, maybe the left system, we can just something like the previous panel, Antonio's suggestion or the Thierry just suggested, we can do the proper lesion preparation, then we still can do a very good long-term result. That's what my thinking.
Okay, so I slightly go on the next step. So we have some discuss with heart team discussion, and the patient the strongly refused bypass surgery, and so we finally decide PCI. So the anomalous origin of the right coronary artery and big circle, relatively small, we decide optimal medical therapy. So this case, I think it's not easy to select one of a specific device for region preparation, NC balloon, cutting balloon, angioscope, and the atherectomy type is rotablation, laser, and a shock wave orbital atherectomy. In our country, we just available different diverse type of balloon and also only available rotablation. But one of the major problem, as you mentioned, the Antonio Colombo acute angle if you're gonna do acute angle rotar ablation, there was some trapped of rotar, and so there is some a very high risk of a population, something like that. So initially, and we select JL4, a French femoral approach. We put the 3-wire LAD BMW, diagonal the cyan blue, LCX cyan blue. IVUS was initially failed to pass LCX region, that is represent how much acute angle, how much calcified LCX ostium. We do LAD IVUS from with LAD to left main and LAD proximal part, LAD ostium part, left main with there is a very severe calcified circular calcium. So we decided to very aggressive LCX region preparation with the NC balloon and use Sapphire NC 3.0. We do the LCX NC balloon, LCX also NC balloon, acute LCX angle is not feasible for rotar ablator. After aggressive NC balloon, we can see and the much improved the lumen and the much improved angle of the suck ostium. Also LAD part and the LAD part NC balloon using 3.0 and proximal part using the 3.5 NC balloon. Post NC balloon and the lumen was much enlarged, and but still there was a circumferential calcium, and I think the angiography looks okay. So and I'm trying to the LCX stand. This is to put the wire diagonal branch LAD, but the LCX stand pass, not passed. And then next step, I'm gonna LAD anchoring using NC balloon. LCX stand pass to try more than 4 times, 5 times, does not pass. And definitely it's all moderator and the panel experience a similar case. So I did the aggressive LCX NC balloon more than 5 times, and then 6, 7 times try, and very luckily passed the stand. And this is the Ultimaster 2.75, 24, and at the final time, very luckily passed LCX using LAD anchoring. So, and the distal part, I put the 2.75, and the proximal LCX ostium, we put the Ultimaster 3.0, 28. And we decide the crush technique, LCS also stenting, and then stent and wire remover. So, and the left main balloon crush using NC 3.0, and then we put the sequential stenting, proximate 3.5 Ultimaster, and the left main 4.0 28 Ultimaster substantially, sequentially, and then prox and the mid part NC balloon using 3.0, left main part 4.0, and then the wiring and the suck using the cyan blue wire, and then after anchoring LCX also opening using 1.25 small balloon. And up to here is very straightforward, and the overall process is good. And then we finally do LCX OS NC balloon 3.0, left main 4.0, and then kissing balloon in both branch. So, and the very straightforward until here. And then looking at the final coronary angiogram, and looks good, and the angle is good, most of side branch good, and this is epicranial view is most of side branch good, and the angiography result is looks fine. So, and we check the final IVUS, and the LCX ostium is widely open, LAD ostium is widely open, left main is fully dilated, widely open. However, story not end over here. This is the real last coronary angio view. You can see what's happening over here. This is areocranial view. You can see some haziness. At the initial time, we can find this finding. And after the patients moved to the coronary care unit and the sudden hypertension, ECG was normal, bedside TTE, we found large amount of pericardial effusion. and we performed immediate pericardial centesis, and then patient moved to direct coronary angiogram catheterism again. We can see the distal part of OM branch. There is some wire damage. There was some leakage of the blood, and that caused the pericardial effusion. We subselection microcaster caravel, and then we do embolization using the gel form embolization, the distal part of the OM branch, and the reason why patient pericardial effusion was not stopped even after heparin reverse. So we finally decided gel form 1 cc, end of the gel form and the distal, the part of the OM branch is bleeding well controlled. So, and the patient transthoracic echo was there is no pericardial effusion at all. Patient discharged well. Patient is now outpatient clinic. The patient status is good. So this is a final discussion point. What should I regulate this case? I select NC volume for calcified lesion perforation. Rota is not feasible for such acute angle with other atherectomy choice. And I'm going to hear some expert opinion for this case for lesion preparation, IVL, orbital atherectomy, or laser lithotripsy. And wire damage, even though I used the very, household, very soft wire, BMW, Xion Blue, in the distal end of there is some damage. How can you prevent other wire choice? And the microperforation, how can you do? Heparin reverse and cross observation usually okay, or versus all embolization is good for this case. And so there is some, I think, some debatable portion for this case. Thank you for your attention.
Great. Very nice cases. So we have discussion times after the full case presentation in lecture 2. And so we're going to move to the second cases. Michael Lee from the United States, he will introduce atherectomy cases for calcified lesions. Michael?
Great. Dr. Park and Dr. Duk-Woo Park and Dr. An, thank you for the kind invitation. It's always a pleasure to be here, and very flattering to be invited. So I have a 62-year-old male. He has diabetes, hypertension, hypercholesterolemia. He's still actively smoking. He has peripheral arterial disease. He had a left PKA, ischemic cardiomyopathy with ejection fraction of 35%. Presented to our hospital with unstable angina and shortness of breath. This is an EKG and echo, and his EKG shows anterior Q waves. And you can see his echo shows apical akinesis. Ejection fraction overall was estimated about 35%. So let me show you his coronary anatomy. This is his right coronary. He has 2 tandem lesions, relatively straightforward. And you can see his apicranial view of the LAD. He has distal left main disease. He has calcified proximal LAD. It's a long diffuse lesion. And distally, it quite tapers off. And there's also a lesion at the distal LAD. Here's a LAO caudal view of the distal left main. He also has involvement of the ostium of the circumflex, so it's Medina 111. He also has a lesion in the up to the lesion of the OM. So I mentioned that he had peripheral arterial disease. He also had iliac stenosis, and you can see a long diffuse SFA stenosis. So this is actually relevant because of his ejection fraction and complex coronary disease and the option of mechanical circulatory support devices. So let's talk about some discussion points. Number 1, this is a diabetic patient with severe LV systolic dysfunction. He has multivessel disease involving the left main, which is also involving the distal left main. We had a heart team discussion, and with a multidisciplinary approach, it was felt that this patient was not a surgical candidate because he had a poor LAD target. He was also had COPD, which they thought that he'd be a poor candidate for surgery post CABG. And the issue of mechanical circulatory support and complex coronary disease, and was not an option given a severe PAD. And also the issue of addressing the distal left main that was severely calcified. So I'll pass it off to some of the moderators and some other discussants.
But this is definitely doable, but I believe some form of circulatory support is definitely needed because there is a lot of work to be done. Considering that the patient is diabetic, we have to be aware that the limitation of PCI, but I may consider using stents only proximally and try with drug-eluting balloon in the distal LAD, in the mid LAD, not to make a full metal jacket. Usually, when I do this diffuse disease, I work with 2 wires, one pressure wire and one regular wire. And I always base my decision not to stent according to the pressure gradient at the end of the predilatation.
Dr. Colombo, how would you address the distal left main bifurcation?
I think I will do my best with one stent and maybe drug-eluting, but drug-coated balloon circumflex.
Or maybe the opposite.
I
Because
know.
the circ is a very important vessel in this patient.
I like to stent the LAD. It depends how I get the LAD after. I should be able to get a reasonable result on the LAD.
Because the lesion looks 101 according to Medina. So in this case, you can go from left main to circ and then do provisional in the proximality. But I think what can be interesting is to know where are the viabilities of the patient. So MRI can be very useful to make good decision. So we don't know if distal LAD myocardium is okay or not, or on EKG there is something.
There's Q waves, and the apex on echo was akinetic. So that's actually very important because of decision making. How far you stent distally.
So I think it's a good argument to go to PCI because it's not a good candidate for surgery, not only because of ejection fraction, but also because implanting a mammary artery in the LAD will not be useful in this case. I think also you should consider treating further right in this case where the ejection fraction is very low. I don't know what will be the best strategy, starting with the right, because it's a very easy lesion. At the same time, if you have any problem in the right, then the patient will go in shock. So I will hesitate and discuss before starting with the right or deciding to start with the right or the left. But I think for the
calcification, how would you address that?
Excuse me?
The calcification. Let me see if I can show you the calcification in the proximal AD.
Yeah, of course. So then I think good non-compliant balloon can be a good option in this case for lesion preparation. I think rotablator can be a problem in this case because you may create some slow flow or no reflow, which the patient will not tolerate with a 35% ejection fraction. Other techniques can be used like lithotripsy, especially for the left main, I think.
So lithotripsy was considered the only drawback was that the lesions were quite severely stenotic. And in my experience, advancing lithotripsy balloon with a larger profile would be a little bit more technically challenging compared to, let's say, just advancing a rotowire or a viper wire to treat with rotation atherectomy or orbital atherectomy, respectively. So let me move on to the case.
Okay,
Okay.
Michael, the concept of a viability concern, actually the patient is low ejection fraction, you know, a large post-MI is an LED. And I think the main issue is how to save the circumflex part. Anyway, technically we have the LED, right? However, I think it's right coronary artery circumflex is more important to, you know, save and maintenance of viable myocardium. And so whatever, you know, you choose, I think is consider circumflex, you know, patterns first. That is my.
Absolutely.
That's a very good point. The circumflex is a very large territory.
Right.
And the presence of Huay suggests the anterior wall is not a huge area for reversible or hibernating myocardium. Great.
Okay,
anybody
go
else
ahead.
before we move on? Yeah, okay. So as Dr. Lefevre mentioned, addressing the right coronary artery would be a very good strategy. So very straightforward. Two stents. All right, so we wanted to do plaque modification. So I chose orbital atherectomy. And the reason why I like orbital atherectomy, because it is very versatile. If you start out with a 125 burr, then you're going to have to take it out, reattach a 1.5, go up to 1.75, even perhaps even higher. But with this device, just with using one button, you can go from low speed, which you take a 125 crown, and going from low speed to high speed at 120,000 RPM, you come out with basically what amounts to be a 175 burr. So very versatile, low crossing profile. So that's what the rationale for using orbital atherectomy was. So several passes, did develop some degree of hemodynamic instability. So we gave 100 mics of phenylephrine, and that restored a blood pressure. So we pre-dilated the LAD with a 325 millimeter balloon. A wire was also passed in the left circumflex. And then we wanted to address the LAD prior to addressing the distal left main. So this is a 325 by 23 millimeter Zion stent. So after we addressed the prox LAD, but did not address the disc or the ostial LAD into the left main, we wanted to pre-dilate the circumflex. So this is a 2.75 by 20 millimeter balloon. During this whole time, blood pressure was very labile, but at this point, when we were working on the circumflex, attesting to the large territory that it was attending, the patient became very unstable. He had hemodynamic collapse. We had known that going into this case that a mechanical circulatory support device was not an option. So the patient promptly received 200 mics of phenylephrine. The nurses were aware to have this on standby, as well as other vasoactive agents. So at this point, it became quite a very complex issue. The patient was very unstable. So was administered vasoactive drugs, including dopamine. So at this sequence, basically just trying to stabilize the patient was a priority. So I didn't have a chance to store all these images. So once the stent was placed in this for a crush, this is just basically a kissing balloon. And then we quickly moved on to putting a 4.0 by 18 millimeter design stent in the left main after the circumflex stent was placed. So we did a DK crush for the distal left main. So we have some degree of restoration of the left main, circumflex, and LAD. We were able to recross the circumflex and perform kissing balloons with a 4.0 15 NC in the left main and a 3.5 by 15 NC in the circumflex. At this point, the patient's blood pressure was somewhat better, was on about 15 mics of dopamine, and blood pressure roughly about 85, 90. So we did OCT, and you can see the OCT run, and the catheter was moving back when we did OCT. What we noticed was that despite doing orbital atherectomy, the stent was still not fully expanded. So despite using NC balloons, we're not able to adequately post-dilate, get full optimization of stents in the proximal LAD. So we used another device to further expand the stent. We used a 3.5 by 40 millimeter shockwave intravascular lithotripsy balloon. This is actually a peripheral balloon. In the United States, the coronary balloon is not currently approved. So this is used off-label, and at initially 4 atmospheres, the balloon is somewhat profiled, and we're able to get further expansion for an underexpanded LAD stent. And you can see here, these are just some of the final angiographic images. Despite intravascular lithotripsy, LAD stent is somewhat better, but still not fully expanded. The circumflex ostium, maybe there's about a residual 20 to 30% stenosis. The patient still required high dose vasopressors. Regarding the distal LAD, we just left that alone, and we're satisfied with the adequate result for the distal left main. So there's some discussion points. Number one is addressing this complex, severely calcified multi-vessel disease involving left main and the inability to use mechanical circulatory support device. So I want to throw it back to the moderators and discussants and see what their thoughts are.
Okay, thank you very much. The very tough case and wonderful results, and we will discuss later after the last presentation. The third presentation is in live number 9 case with an interactive discussion, lithotripsy treatment. This will be presented by Dr. Antonio Colombo.
So I think lithotripsy is an excellent, safe and practical way to get optimal lesion preparations. I have no conflicts to disclose. As you can see, this is a large mid-LAD, very large vessel. You can, is clearly calcified. You can do high pressure balloon inflation without any questions. You can do autoablation and high pressure balloon inflation. Definitely we did for several years this approach for more than 20 years with good result. So you wonder, why do you really need something new now when you worked pretty well for 20 years? The answer is that we look for better results. You see the OCT shows pretty bulky calcium, you see in between 9 and 12 o'clock to the whole area. You see the steel frame, there is a pretty dense, especially in C, a big chunk of calcium. So we decided to do standard lesion preparation with a shockwave. Sometimes the shockwave balloon does not cross, and you need to predilate with a semi-compliant balloon. In other situations, you even need to do autoablation. So we did 4 sessions. After the first session, the balloon, the 3.5, was full dilated, and a total of 8 sessions in the all LAD, and then we repeated the OCT, which shows a better morphology. As you notice, there is some dissection, but nothing dramatic. These are the cracks as the lesion, where there is the asterisk is a branch. Then we did additional pre-dilatation with non-compliant balloon. Almost always do a non-compliant balloon dilatation up to 24 atmospheres, 3.5. And this after lesion preparation. The result is quite acceptable. I am not so sure that we would have obtained such a result with a simple high pressure balloon dilatation. Then we implanted a stent. We had to use a guideliner to deliver a 3.5 24, and we post-dilated at 24 atmosphere. And this is after stent implantation. But what is more important is the OCT image. We are impressed by the circular morphology. It's not easy to get this round morphology if you do just high pressure balloon dilatation. And I believe these are the advantages of this technique. And we have to demonstrate with follow-up if with this favorable morphology you can achieve lower late loss. My impression is that if you have circular morphology, you will minimize late loss, which means minimize restenosis. But this needs to be proven. But be aware that this is not only a goal of the shock wave, it's a goal of the high pressure balloon, which was applied after the shock wave and after stent implantation. Here is the baseline. Look at the difference between A and small a, B and C, really. And again, I am impressed not much by the lumen gain, but the circular morphology. Having shown these, I would like to add the shockwave is a very useful tool with many advantages, especially related to safety. Nevertheless, there are limitations, and we should not assume that this device is good in every situation. This is one example. You see that a calcific lesion with calcium only in one segment, very asymmetric stent expansion. The stent has already been implanted following high pressure dilatation, and high pressure dilatation will expand the stent towards your left, but leave the calcium untouched. Shockwave was done in the stent, and you see an improvement, no question. We go from an area of 4.5 square millimeter to an area of 6.7, but we cannot achieve a round symmetric expansion because the calcium is focal. And even if you do shockwave, we may not be successful to fully break the focal calcium, and the final result is still suboptimal. So this information should be obtained at the baseline, and if the calcium is granular and not diffuse at least 180 degrees, you may get an improvement with shockwave, but is not going to be the one that we saw in the first case. And that may be a good reason to use a different technology like orbital atherectomy, maybe cutting balloon, and do not use the shockwave if you do not expect to have a good result. This is again the summary. Baseline, you see the focal calcium with expansion of the stent asymmetric. After shockwave, there is a better stent expansion. The area will go from 4.5 to 6.7, but still you see an asymmetric expansion. As I said at the beginning, do not assume that shockwave is the solution for everything. You still need sometimes rotablator to allow the shockwave balloon to cross. And in some situations, even after the shockwave, we needed high pressure OPN balloon to fully expand the stent because the shockwave balloon did not achieve the result. This is one example. This is a post-shockwave trio, then following 22 atmosphere pre-dilatation and implantation of a trio drug-eluting stent. You see very asymmetric lumen, as I shown before. These we repeated a second shock wave, and then we repeated a non-compliant balloon at 24 atmospheres. And you see again incomplete or asymmetric stent expansion. Then we went with the OPN balloon at 37 atmospheres, a trio, and now you see a big difference. The stent is fully expanded. So the message is that do not rely on a single device. Sometimes you need multiple devices. I don't know, maybe in this case we didn't have to use shockwave from the beginning, but I think combining different devices is sometimes important and necessary. So shockwave technology is very important to break calcium with extension 180 degree or more. Most of the time, no significant side complication reported except for rhythm disturbances and coronary spasm. I must say that rarely you get vessel rupture, but not zero, because we have not seen ourselves, but I saw reports of coronary perforations after shockwave. So it's rare, but it's not zero. And thank you for your attention.
Okay, thank you very much for a wonderful case and presentations. Yeah, any question or comment from the panelists?
I like very much the presentation of Antonio. I think it's based on the experience, and I think it's very important to underline the fact that OPN NC balloons are very useful. I think it's still underused in the world, and it's very important to know that sometimes you break the lesion after using other devices before, up to 40, 45 atmosphere. So this balloon is really very important, even after using shockwave or rotablator. Sometimes the lesion is, you are not able to break the lesion, especially after implantation of the stent too early. So very important to have this kind of balloon in the cath lab.
Yeah, and if I may add one point to Thierry, no question that every time you do aggressive lesion preparation, you take a risk. So always be prepared. It's rare, but be prepared. Have cover stent available, have all devices you need, because it's a matter of skill, but it's also sometimes a matter of luck. Sometimes the vessel breaks. But if you use OPN, we try to undersize 0.5 millimeter first. I prefer to undersize 0.5 millimeter because
it's exactly what I wanted to say. So it's very important if you use high pressure to downsize the balloon. Many people think that they should upsize the balloon in order to be able to break, but it's a big mistake. So downsize and go to high pressure.
Yeah, absolutely. You learn these after you had the several vessel ruptures.
Of course.
After 30 years, very clear to me.
So I just want to say that we always say that PCI is really a combination of skills, judgment, and experience. Certainly in treating calcified lesions, we need a combination of all three. But I just comment on the shockwave balloon again and talking about a limitation. So we always talk about shockwave use to prepare a lesion, but sometimes we actually prepare the lesions for the use of shockwave. For example, when you have a very tight blockage, you need to facilitate it by pre-dilating it with a non-compliant balloon. When you have a very angulated lesion, you can't expect it to go down. You might have to use a guide extension to facilitate the entry of the shockwave balloon. And I think that the one of the limitations of current shockwave iteration is its high incidence of rupture. So it occurs in about 2% of cases when you use a shockwave balloon. And it's very frustrating because in the very first pulse, you could actually have the balloon rupture and you have to take out another balloon and so forth. And this is because when the calcium arc gets broken, sometimes it can tear into the balloon and it might puncture the balloon, which is currently very thin in terms of its and its surface diameter. So they are coming out with a second iteration, which is much thicker and its balloon. And also shockwave is not good if the calcium cap is very, very thick, because you just simply cannot break it up. You need to somehow modify, thin it out, you know, like an orbiter or something like that to help facilitate breakage. And finally, I also think that in calcified nodule, shockwave is also not very helpful. You might again need something like an orbiter to help to deal with calcified nodule lesion.
Okay, Michael, I have one question for your case. Your case is a very tough case. You initially do orbital atherectomy from the left main proximal LAD and then put the stent, and then lastly you apply the shockwave, right?
Right.
I'm wondering, is it okay after stenting, you apply the shockwave, any damage of the stent? You expect outside of stent some calcium cracking is possible?
Yes, that was a very good question. The idea was used more as a rescue technique because despite our best efforts to lesion prepare and put the stent in and post-dilate, the stent clearly was underexpanded. So the risk of restenosis, but more importantly, stent thrombosis was a real issue. So it was used more as a last-ditch effort to get more stent expansion. The use of IVL immediately post-stent, we just don't know how it's going to affect the stent, affect the polymer. But more so, it was just a mechanical issue. And clearly, the NC balloons that we had at our institutions, we don't have the OPN. It was not providing that satisfactory result that we were looking for. So again, this was even a peripheral balloon with a larger profile. So it was just moved as more of an act of desperation to prevent a target lesion failure in the future.
Okay. Yeah.
So Michael, I actually have a comment on your case because I thought it was really complicated in somebody with poor LV function and hemodynamic compromise. And I thought when you have a diffuse LAD stenosis of this nature, perhaps orbital atherectomy is not so safe compared to a rotor-bladed because orbital requires you to actually have a travel rate of 1 millimeter per second. So you have to do it slowly, back and forth and so forth. When you have a very tight blockage and a long disease and a poor LV function, I'm not sure whether I would actually take this length of time to try to ablate the lesions the way that I could actually accomplish with a rotor-bladed, which is much quicker.
That's a great point. You know, the technique of rotation atherectomy, some people like to go very fast back and forth. I've seen a lot of the Japanese go back and forth like a windshield wiper. I've seen also other people do a very slow pecking maneuver. The rationale for me using orbital was that unlike rotational atherectomy, where when you spin, you're at one basically axis. So perhaps it increases the risk of dysembolization and no reflow phenomena. With orbital, because not only do you rotate, but you also are elliptically contacting the vessel, it in theory perhaps maintains flow, less risk of hemodynamic collapse from slow reflow phenomena because you're actually actively having blood flow. Think about where there is a severe stenosis, rotational atherectomy will go down the same path of least resistance after you pass, whereas with orbital, it won't go down the same path. It'll continue to ablate 360 degrees. So there's kind of a different pros and cons of both devices. But the other reason why I use it, as I mentioned before, is that because you could go from low speed to high speed, you get similar outcomes to 175 Burr without having to exchange catheters. And in this case, you really need to work very expeditiously. And I didn't think you have enough time to go back and forth. So the number one, the crossing profile with the 125 crown, and when it doesn't cross, actually it has a similar to a Dynaglide. We have what's called a glide assist, where it rotates 5,000 RPMs. So that's also very helpful, but a very good question.
Okay, any other
Okay.
comment? Yeah.
Dr. Han, Jung-Min, from any suggestion or question from Stanford?
Oh, yeah. Congratulations, Dr. Lee. I fully agree with your treatment and the final result. So regarding the Dr. Lee's case, I think that yes, the simple crossover would be the best way to treat the distal left main bifurcation. But sometimes that is due to the better long-term outcomes. After simple crossover stenting, then the bifurcation stenting. But sometimes the acute result is way more important than the long-term result. I think that this is the case. So the depressed elbow ejection fraction and the high risk of hemodynamic collapse if we lose any side branch. So your decision for the initial two-stent technique and to save the side branch flow, the crush technique would be the good option for this treatment. Congratulations.
Okay, Dr. Lee, yeah, I would like
Okay.
I would like to ask about the timing of orbital trial ablation, right? Yeah, if the calcium is to the site of the myocardial site in the LAD during pullback, we can use an orbital atherectomy very well. But if the calcium is located in the epicardial site during pushback, you can try the ablation using a wire bias, right? So it is very important to confirm the distribution of the calcium when you use an orbital atherectomy.
Yeah, very good point. Ideally, in a perfect world, it'd be nice to do intravascular imaging just to see. The lesion was so tight, even crossing a wire was quite difficult, and it required several passes just to cross. But yes, in the truest sense, defining the distribution of calcium would be ideal, but unfortunately, something practical or feasible.
Thank you all for the discussions. As the last special lectures, I'd like to invite Akiko Maehara from New York. She will give us imaging guidance for calcified lesion PCI. Please.
Okay, so today I'd like to talk about how to define the calcified lesion. So this slide to show the relationship between the angiographic calcium compared to the intravascular imaging calcium. The first point was, if you have the moderate or severe calcium angiographically, when you do the imaging, you can see the big chunk of the calcium. And the second, on the other hand, if you don't see the calcium by angio, such as this, but still sometimes you see the big calcium if you do the either IBAS or OCT. This is a kind of the case. In the distal right coronary artery, by angio, we don't see any calcium. And if you look into the OCT, I can see the very circumferential calcium. However, if you look into the OCT, there is a calcium which is exactly same as IBAS, but this calcium is thin. That is the reason we couldn't see by angio. So to answer that kind of question more clearly, we picking up the cases by IBAS. Maximal calcium angle is 180 degrees, And then we compare the angiographic visible calcium versus non-visible calcium using the OCT. And OCT can tell us the thickness of the calcium. For those which we couldn't see the angiographic calcium, those calcium was majority is very thin. Therefore, they are not going to inhibit the stent expansion. And we can see the nice stent expansion, even the big calcium, either by IVUS or OCT, because they are thin calcium. So the first point was, angiographic calcium detection was actually not too bad. And if you don't see the calcium by angio, overall calcium as a volume is not too much. And most likely those are thin calcium. So even though you see the big calcium by IVUS, they are not going to inhibit the stent expansion. To answer that kind of question more systematic way, we did the study to make the score by OCT, picking up the two separate cohort. And then we ask, using the stent expansion as outcome, what kind of calcium morphology to predict stent expansion after adjusting the procedure factor? All calcium components is important. Large calcium angle and thick calcium and calcium length, all of them were independently predict the stent expansion. So based on this regression coefficient, we developed the score, and the smallest is 0 and highest is 4. All of these components is important. This is a summary based on the validation cohort. And if you have the score 4, they have the poor expansion. But we have to understand what is the key to make the good stent expansion in the severe calcified lesion. The mechanism is really facilitate of the calcium fracture. This is a cohort which was treated without any modification device such as lithotripsy or atherectomy, using only balloon and stent. And y-axis is minimum calcium thickness, and the region who got calcified fracture is, except this region, all of them was less than 0.5 millimeter thickness of the calcium. So the prediction of the calcium fracture, the most important factor is the thinnest calcium. If that is thicker than 0.5 millimeter thickness, most likely you will not get the calcium fracture even if you do only the balloon and stent. So you need something more. Based on the OCT calcium score, we developed the calcium score based on the IVUS, and we decided to be more practical. And because we learn angiographic calcium is okay to detect to start with, we take it out if there is no angiographic calcium to start of the score. So angiographic no calcium was out. And the next we learn the big calcium is important, but less than 108 degree of the calcium is not important based on the OCT. So we start from the more than 270 degree of the calcium. And if you have angiographic calcium and IVUS tell more than 270 degree, we start calculating the score. So those are the data based on the test cohort to decide as an important factor. The first, maximum calcium is more than 270, and the total length of the 270 calcium is longer than 5 millimeter. The long big calcium is the most important. Second, circumferential calcium. 360 degree calcium is completely different compared to, let's say, 340. If you have some location which don't have the calcium circumference, those are the good place to making the good dissection. And calcium nodule is important. This is a marker of the big chunk of the calcium behind, and also making the bad symmetry after the stent, and also long-term outcome. It's something unique effect. This is important. And finally, many times when we look into the calcified lesion, we forget the vessel size. But we recommend go to the calcium site and then close to the calcium site, but somewhere you can measure the vessel size measure. And if the vessel size is less than 3.5 by media to media, that's a small vessel. And because of the small vessel, they have less capacity to expand. They are more likely under expansion. Any of them, we put score 1, and total is 4, and smallest is 0. And if you have more than 2 score, we consider the atherectomy. So this is the data in the validation cohort using the score based on the test cohort. If you have the high score, you see the poor expansion. And we calculate this score based on the atherectomy cohort. And the atherectomy cohort, even the high score, now you see the good expansion. And we pick up the non-angiographic calcium cohort, and none of them, those are calcium score 4. And even the calcium score 3, they are good expansion, indicating those are thin calcium, which IBUS cannot tell, but that's kind of the process based on the angiographic appearance. And there is a very clear interaction in the treatment effect in relation to the score. Even the high score, more than 2, if you do the atherectomy or lithotripsy, you have the better stent expansion compared to the balloon or stent only. And this is a case example, the calcium score 2, based on the long, big calcium and circumferential calcium. And we couldn't do the IBUS for this case before the treatment. And first, rotablator 1.25 and 1.5 and non-compliant balloon was performed. This is IBUS picture after this treatment. And you can see at the site of the IBUS, that's indicating the place where the rotablator effect. And you can see the nice reverbation that's indicating the modification of the calcium. However, we don't see any fracture. And we saw this is not good enough to go ahead to the stent. And then we did the 2O bar by rotablator and non-compliant balloon. And after those treatment, now we can see the nice calcium fracture by IBUS. And then we are confident if we put the stent, we should be able to expand well and they go ahead to the stent. And this is how it looks like after stent. You can see the fracture site stretching better. Now you start seeing the behind tissue. This is a way to recognize the calcium fracture by IBUS. You start seeing the behind because no longer the calcium exists here because this calcium separate here and here. Let's talk the orbitory and rotablator more by OCT. So the first, you have to look into where the wire or OCT catheter is located. Those are the place where the rotor or orbitory is going to be ablate. So this is the expected slice, which we can get the ablation. And definitely, yes, we can see the nice polished surface by rotablator. And this is how it looks like after the stent and non-compliant balloon. At the site of the ablation, we can see the nice fracture. This is typically what we can evaluate by OCT. How it looks like orbitory, this is quite similar appearance. At the site of the OCT catheter, you can see the nice ablation by orbitory. At the site of the orbitory, you can see the nice calcium fracture. But also, we can see the calcium fracture which don't have the orbitory modification. But if we compare these fracture, you can see the difference. So this is a summary. We compare the calcium fracture at the site of the orbitory modification versus no. First, if you have the modification, you have more fracture. Second, if you have the modification, even though the calcium is thick, you can get the fracture. So seems to be either rotor or orbitory making the polishment and then thinner, and probably the hardest point of the calcium is surface. Taking out the surface, we can get the good calcium fracture. We compare the rotor and orbitory in terms of the effect, and 99% both devices work at the wire bias segment. Second, orbitory is better if you have the intermediate size of the lumen or calcium is small. In terms of the wire bias, in terms of the differential cutting, seems to be the rotor is a little bit better compared to the orbitory. Additionally, this is a case example. The case was done rotor and cutting balloon versus rotor and conventional balloon. And we see if we do the cutting balloon after the rotor, we see the more calcium fracture and good fracture. And you can see the good stent expansion compared to the conventional balloon. And this is a summary. All of the cases was treated by rotor and following cutting balloon versus conventional balloon. First, you see more calcium fracture. Second, even the big calcium, you can see the more fracture using the additional cutting balloon after the rotor ablator. So seems to be there some additional effect by using both together. And finally, this is a lithotripsy, the very severe calcified lesion, and finally good stent expansion, and how we can see the effect by OCT. And of course, the lithotripsy is completely non-related to wire bias, and we can see the nice fracture even without non-compliant balloon sum. And also, there is a very multiple calcium fracture circumferentially, even the big lumen area segment. But as Dr. Colombo mentioned, after the non-compliant balloon and stent, we see the much more calcium fracture and also the stretching calcium fracture that's contribute of the good stent expansion. So finally, let's talk a little bit for the instantly stenosis. We know if the patient coming about less than 1 year, most likely stent under expansion, and more than 1 year, most likely neo-atherosclerosis. So this is a case example, patient having a recurrent instantly stenosis, and even the balloon, we couldn't see any stent expansion. And we see the OCT, and we found that's instantly stenosis, it is due to the under-expansion from the beginning. And the big chunk of the circumferential calcium behind stent, and only the small amount of the non-intimal aplasia making this type of the instantly stenosis. And for this case, laser was performed, and then after the laser, we don't see any effect yet. But after the additional non-compliant balloon, we see the calcium fracture behind the stent. And we compare the cases who had instantly stenosis due to the under-expansion due to the peristent severe calcium compared to the laser versus balloon angioplasty only. And we see the more fracture behind the stent and getting the good lumen area compared to the balloon angioplasty only. Now, atherosclerosis in the stent can be calcified nodule in the stent or such very thick calcium. And this is a summary of the second generation instantly stenosis. And after 5 years, the calcified atherosclerosis up to 43%. And we ask ourselves, what is a predictor of the good stent expansion in the neo-intimal calcium? And the answer is quite similar if you have the thick calcium or if you have the big calcium, similar to the de novo lesion, that's predict the stent expansion. So finally, based on this under expansion, if we follow up the patient, if we have the poor new stent expansion, they have poor outcome. To conclude, angiographic invisible calcium is most likely thin calcium and it does not inhibit the stent expansion. However, you need to caution if your angiographic is not very good quality, that cannot be reliable. We have to think about how to make the imaging guidance. We have to consider the total calcium volume, not just one slice having the circumferential. You have to see the thickness, angle, and length. And all together, that predicts stent expansion, even the de novo instant calcified lesion. And mechanism of the good stent expansion in the severe calcium is really facilitate calcium fracture. So that's the key of the expectation. And finally, what work in terms of the atherectomy or lithotripsy or calcium modification is really facilitate calcium fracture, even the thick calcium, and result in the good stent expansion. Thank you.
Okay.
Great. Akasaka,
Yes.
any comment on that one?
Thank you very much, Akiko. A wonderful summary of the approach to the calcified plaque, right? Yeah, I would like to ask about the 2-3 issue, right? So you showed the final result of an balloon and atherectomy and score, right? So, but even in case with an atherectomy, the calcium score is 2 or 3. There are only a few cases, but still some under expansion. Are there any specific morphological character in that case?
Thank you so much. That's very important. Good eyes to pick up those cases. And I couldn't answer now because we didn't look into for those specific cases, but I do understand the reason was we didn't consider well before putting stent, meaning we did already atherectomy and we did non-compliant balloon. And then we thought that's already enough. Based on the non-compliant balloon, we see some expansion by angio. And then we thought it's ready to go, but it was not. So I think that especially the very severe calcified cases, we really have to confirm whether it's ready to go. Those cases, I think still we are not enough in terms of the preparation.
Okay. Another question is an effect of the laser. You showed a wonderful case with an stent under expansion surrounded by the circular calcium, right? And then you did an ERICA, and after ERICA, you did a high pressure balloon, and you could get a good expansion. At that time, I think the lithotripsy shockwave also might be effective if you want. Are there any experience you have such treatment?
I'm sorry, my answer is no, but we don't have such experience. I would ask Dr. Colombo and other colleague, but based on the mechanism by looking the de novo lesion, I do think that should work best actually using the shockwave. So please comment the shockwave for the instant stenosis.
Antonio, you have an experience?
We used quite a lot shockwave for instant restenosis. And again, we didn't see any damage to the stent, even when we looked by OCT. And we also use the shockwave acutely. If after stent implantation, the result is not very good, we perform shockwave. So I think can be used. Again, the calcium needs to be at a certain extent. If the calcium is focal, is not effective.
I see.
So you must have a certain amount of circular calcium. Nodular calcium, if it's effective, is a piece of luck.
Just one comment about this question. I think it's very important. We had a similar experience with Antonio when we see patients coming for a pseudo instant restenosis just because the stent was not fully open or deployed. We use the shockwave technology, and it's working in the vast majority of cases. So I think it's very important. And the other point is, of course, intracorneal imaging is very important in the field of calcification, but we should remind that we have a very simple tool that we can use also, which is stent boost or stent vis. We use always this after stenting just to check that the stent is fully open, and I think it's very important.
I see.
So not only is lithotripsy effective in the under-expanded stent from external calcium, but it's also very effective for calcified new intimal instant restenosis. So because there's no other options except for this particular device, which now gives us at least some kind of solution to these problems.
And my final question is the very eccentric, very thick calcium in the one side, and the other side is it looks very normal. And if you try to dilate using a bigger balloon, higher pressure, I'm wondering is the perforation of the normal site. So at that time, we have to pay attention to the size of the balloon. Have you any experience about the such experience? Akiko or other?
But let me start by myself. I think that's very important. Even though we are saying the total amount of the calcium is causing the expansion, those are the other one cohort, which I call the malignant calcium, which not super big, but typically very thick and eccentric and negatively modeling, and typically in the mid LAD. And for those, because by IBUS OCT, even we can see, it looks small, it's not much, but we have to remember how vessel was. And if you expand, you perforate in the pericardium side. And important, if you do the IBUS OCT, you can recognize where the wire bias. And if this is really hitting to the eccentric calcium, you have the better chance to ablate. That's, I think, the very, very important.
Right. Thank you.
Yeah, Akiko, very, very correct, very correct. You are absolutely right. Negative remodeling, focal calcium, especially in diabetics, it happens. And really, we cannot anymore have vessel rupture without. It's an unacceptable complication. I hate that.
I see. Okay. Any other question or comment to the yes?
Just one question regarding that Japanese style cutting balloon NSE. I don't know if the Japanese colleague can be explained, compare with regular Boston device cutting. What is the difference? Because the nylon, the cutting edge, is that the different compared with the Boston?
I think, I'm sorry, go ahead.
Please, yes, please.
No, not myself. I would ask Dr. Nakamura or Dr. Akasaka, yeah.
No, I'm the moderator, so please, Akiko, go ahead. Yeah, right.
All right.
Dr. Nakamura?
Dr. Nakamura? He's not.
Shigeru Nakamura is not here.
All right. Okay.
Okay. Duk-Woo and Jung-Min all right. In your practice, actually, so we tried at first any calcified lesion. If non-compliant balloon passed, actually we tried a non-compliant balloon high pressure inflation up to 30 atmosphere, 35 atmosphere, and if in those cases undilatable lesions, as we're gonna think about the atherectomy device, it's a practical point of view, right? So would you tell us as in your case, Duk-Woo, Jung-Min, and in your practice, you do a lot of non-compliant balloon without, ablation and the other atherectomy devices. So could you tell us some point of that practical issue? So for the road ablation, road atherectomy, and just non-compliant balloon inflation.
Yes, so I think in my case, in practical viewpoint, I definitely believe if non-compliant balloon past the calcified region, severe calcified region, I definitely expand the perfect region preparation for the lesion. But however, if non-compliant balloon does not pass, and I usually move to the atherectomy device. Just in Korea, we just available for rotabulation. Some, in the next few years, we are available on other types. So in practical point, non-compliant balloon passed, I definitely treat well using non-compliant balloon. And Dr. An, any comment?
Yeah, I think it also depends on how the lesion is reachable with the stents. So sometimes you have a lot of calcification proximal to a tight lesion, and you can open the lesion, but then you are not able to go with the stent. So I think in this case, rotablation first is a good option because you smooth the vessel and you facilitate access to the lesion. So I think it's a very difficult discussion because There is cases I think we should go directly with autablator, and there is cases we should try first with non-compliant balloon. And there is also today cases where shockwave technology can be a good option at the first attempt, especially for calcified distal left main lesion, for example.
Akiko, I have one question to.
Go ahead. Sorry, go ahead.
Go ahead. Go ahead.
Yeah,
Go ahead.
let me comment one thing before moving to you answer your question. So in terms of the uncrossable lesion, and I think that I understand the comment. If you are not cross the non-compliant balloon, you go ahead to the rotablator. That's quite always people do. But in such region, actually, we analyze those type of the region, and 15% of the region is actually the calcium is less than 100, less than 270 degree, meaning not super calcium. For those region is actually very angulated and tortuous, meaning at least you have 2 angulation before reaching to the region or at the region. And then you have most of the time, those calcium is at the shoulder of the wire bias, and then those are the hitting to the balloon to move forward. And then once you do the rotablator, and then you shave the shoulder calcium, which typically not too big, and then you can pass. And then after you pass the non-compliant balloon or IVAS, actually we surprise, it's not too much calcium. It's really those shoulder calcium inhibiting passing the balloon. That's I'd comment. We analyze all rotablator atherectomy cases at Columbia. Out of these, 15% of the cases which require the rotablator because of the uncrossable was calcium was less than 270. So that's also important at the other way. It's not always super calcium causing the uncrossable. Okay. Sorry. So go ahead to the question, Doctor.
Akiko, I have one question to you. So is there any relationship between the lumen area within the calcified lesion and stent expansion? My assumption is lumen is very tight, the stent expansion would be very bad, or the calcification not easy to be broken, but lumen is not enough anyway. There is some lumen, then the calcium would be easily broken by the high pressure balloon, something like that. Do you have any idea on this?
Yes, I think in terms of the lumen before treatment, there is a 2 important factor. One is, as you ask, if the lumen to start with is relatively mild or moderate size, of course, they can have the good stent expansion. So that's, of course, yes. And pre-lumen is really effect of the outcome. That's yes. But second is, if the lumen is intermediate, rotablator doesn't work because there is no space to shave. So I think so answer, that's 2, yes.
Okay, I would like to back to the Dr. Wu's question. Are there any difference between cutting balloon or scoring balloon use for the severe calcified lesion? Are there any difference? Is it the right, Dr. Wu? You try to
NSE alpha.
Yeah.
The new Japanese style of cutting.
Yeah, so I think we prefer the cutting balloon. I think maybe the strong braid is concentrate the power to the calcium. So if the very eccentric lesion, we prefer the NSC because of safety issue. But when you have a safety, we prefer the cutting balloon stronger.
We use a cutting balloon at high pressure, like 22 atmosphere, always undersize, 0.5 millimeter.
Great.
And only that is an off-label use because Boston usually recommended not to go.
Cutting balloon at high pressure becomes semi-compliant.
Okay.
So you have to take this into account. But it's very effective. We got expansion after failure of NC balloon, and cutting balloon at high pressure was successful.
True, we have the same experience.
But he's off-label. Okay.
Off-label.
Okay. Takashi?
Yes.
It's close.
Yeah, right. Okay, yeah. Tonight we had a very wonderful case presentation and discussion, and also the very meaningful, fruitful lecture from Akiko Maehara. And I really appreciate all the presenter and also the panelists to join the very hot discussion. And yeah, severe calcified lesion is still a big issue in the daily practice, and also the imaging is very useful. But we have now lots of technique to approach the calcium, and a combination of each technique is the best to overcome the calcium, I think. So, Dr. Park, is it okay? My summary?
All right. Great.
Okay, great.
Great summary. Thank you again for you all, the Complex PCI 2020 virtual. Really, I'm looking forward to seeing you all in the next time, face to face. And really, thank you again for joining us.
Okay. Thank you very much.
Thank you.
Thank you.
Thank you.
Bye-bye.
Thank you.
Bye. Bye.
Wonderful. Thank you.
Yeah.